Hello and welcome to this update on guidelines of AHA. Those who have missed this 2025 update, I'm here with you to give you the broad view of what has changed in BLS basic life support and advanced cardiac life support guidelines. So let's begin our journey. First, you should know Utstein formula for survival. So what is Utstein formula? So this was the basis on which the AHA guidelines were framed long back in 1966 when they wanted some standardization for resuscitation. And ILCOR, the International License Organization Resuscitation, came together, and with the development of these three pillars like medical science, educational efficiency, and then local implementation, and all this for what? For saving lives, for improving the survival of the patient. So this is how the update began. And what is the overview of this update? One and foremost importance is BLS, that is high quality of chest compression, which keeps the circulation to the brain and the heart. Second is the early defibrillation. Then the integration of ECMO for return of circulation, that is advanced resuscitation techniques. Post cardiac arrest care is very important to have a neurological intact patient. So target temperature management, the duration has been defined here, and what are the targets of hemodynamic stabilization to be maintained. Of course, there are certain populations like a pediatric patient, infant patient. I may not cover that, but in pregnant patient, sometimes you get in the ICU and you should know what are the specific resuscitation guidelines for these patients. In this guideline, there has been strong focus on continuous training and education for all, for the community, for the lay rescuer, and for the medical professional. So here, with this presentation in next 20 minutes, I will be covering the important updates according to the CAB protocol, compression airway breathing, that was brought long back in 2015, and what are the frequent changes which have been made in 2025. Let's review. Before going to that, we should know what is the epidemiology and outcome, some numbers, and how the survival and evidence is developing. If we see OHCA, that is out of hospital cardiac arrest, these are the figures from the American Heart Association. Of course, we don't have these figures for our population, but with the lay rescuer, it's definitely significant amount of survival, 13% versus 7.6% in unwitnessed cases. And if we see only 41% of the population get lay rescuer CPR, here lies the importance of training the community, making them aware about the basic life support and cardiac compression to improve the survival. It is higher if the cardiac arrest occur in the public places with the public access device like AED is available. The significant survival 21% versus 8.9% in the residential place. Similarly, intra-hospital cardiac arrest, the survival is better, that is 23.6%, and only 79.2% has favorable neurological outcomes. So the goal lies in prevention. Coming to the chain of survival, so they have assembled the 6 links of chain of survival into one for adult pediatric, and this is what the chain of survival looks like in 2025. So recognition and emergency activation. Second link is the high quality CPR, which is very important. Third is the defibrillation with the use of AED public access device. Fourth is the advanced resuscitation care. Fifth link is the most important of post cardiac arrest care in the best ICU. And last link, the sixth one added, is the post recovery and survivorship of this patient, and follow up to 6 months, 1 year, what happened to these survivors and how to make the group and help them out to continue and the quality of life. So this is the 6 links of the important chain of survival which is given into 2025 update. Some terminologies which you should understand, like rescue breath, layperson, bystander. These terminologies are outdated now. There's no point in confusing people with breath. Breath is rescue breath. What is rescue breath? Don't confuse. Breath is a breath. So anything which causes the visible chest rise by the means of mouth or pocket mask by a lay rescuer who is actually working. So bystander has negative impact. So somebody standing. So lay rescuer is active participation. So the terminology accepted now is for the community resuscitation is lay rescuer, the breath which causes the visible chest rise, and anything you use pocket mask or back wall mask to improve the respiration, that is known as ventilation. There are two terminologies. If you are successful with resuscitation, you come a return of spontaneous circulation, or the return of circulation was with the mechanical means like ECMO. So that is return of circulation, ROC. Coming to high performance team, this is the triangle of success or triangle resuscitation triangle. The roles are the three major roles is the airway, compressor and defibrillator or monitor. So what is the role of a compressor is to perform compression, assess the patient and rotate every 2 minutes. The airway person has to take care of the airway, oxygenation, oral airway adjuncts, back wall mask ventilation, and defibrillator person has to monitor the rhythm. He has to be kept in the monitor in such a way that it is visible to the team leader. If you have more number or 6-person high performance team, one has to be team leader who assigns the roles and responsibilities. And IV or IO medication, though IV medication is preferred with the bolus of saline, so the drug reaches the circulation. And time recorder is very important to calculate what is the code time and what is the time for compression. That we'll see is very important for any successful high performance team. What does the high performance team do? There's timing to first compression is improved, time to first shock is important, time is heart, time is brain. Optimize the cardiac compression fraction, that is said to be more than 85%. Early response team, the rate and the depth of the compression, what quality compression are giving, how you are avoiding the fatiguing, whether you are using the feedback devices, how is the communication within the team, what is the coordination, what is the communication, and what is the leadership role. All these are measured metrics with CCF, which is an important metric for success of high performance team. So coming to first component, that is circulation, that is CAB compression. So they have suggested the use of feedback devices to do the compression. The Lund University cardiac arrest system, that is Lucas, which causes the mechanical compression, is not recommended until unless you are transporting the patient, maybe there, but evidence is very low for that. The patient torso should be approximate the knee of the rescuer is performed with the hand compression with the two hands, which I have discussed in my earlier video, and the use of personal protective equipment to prevent from the nosocomial or other infections, because it is an aerosol generating process and the rescuer should not get infected. After COVID, this is a standard of care. The head up CPR is however discouraged, so patients should lie flat on the flat ground. In this picture they emphasize the role. You can see the two arrows, where is the knee of the rescuer and where is the hand is standing on top of the patient on the firm surface, patient torso at approximately at level of new rescuer. This gives the exact compression and relaxation of the heart. So you are compressing adequately, and this is the at least 100 per minute and adequate depth of compression, and this will lead to improvement in the cardiac compression fraction. How to calculate? You see here, as you start compression, the coronary perfusion pressure increases and there is a steep fall. The time immediately it steep falls if you drop the hands. If you remove the hand for other activities, the compression stopped, it goes down and further starts to build up once you start the compression. So these interruptions will prevent the good cardiac as well as neurological recovery. So in code time, what you have to monitor is what is the time of arrest, what is the time of return of spontaneous circulation, that is your T1. And second, you use a stopwatch to see how much time you have in the compression, and if you take the ratio T2 to T1 should be more than 85% if you want the good survival neurological intact patient. That is your aim for cardiac compression fraction. In infant compression technique, I am not going to go in detail, but yes, the two finger technique which is eliminated by the palm, you can see in the figure, instead of two finger, the palm is used with for compression, and thumb encirclage technique can be used for single rescuer, but the two fingers which were used, which supposed to be inadequate, have been eliminated from these 2025 guidelines. Coming to A part, airway breathing circulation. So major change in foreign body airway obstructions. So what our mothers used to do when you used to choke in the childhood, back blow. So 5 back blows and 5 abdominal thirds. So back blow come first. Provide the breath in lay rescuer, they encourage giving breath, and now instead of 1 breath every 5 to 6, they have defined 6 seconds. So 1 breath every 6 seconds and 10 breaths per minute. That is what should be the aim for breathing in resuscitation. Point of care ultrasound, you can use this advanced technique, but without chest compression. Maintain your cardiac compression fraction, as I discussed, more than 85%, and ECPR if possible to return of circulation, not spontaneous circulation, in cases where you have ECMO facility. So this is a new algorithm for a foreign body airway obstruction. Choking when the patient is cyanosed, unable to speak, alternate mental status. You activated the response system, and here you start with your 5 back blows. So 5 back blows followed by abdominal thirds. If it's not expelled, then you go to your basic life support protocol and check for the visible object in mouth after every compression, after every 5 chest compression, 1 cycle of chest compression. You look for the visible foreign object. Do not try to find out a blind finger sweep, as in old guideline as well. What's new in the BLS algorithm is initially it was public access device AED. Also, they now want to keep the public access naloxone. If you have suspected opioid overdose, respiratory earliest use of naloxone may help before the patient reach the hospital. So no criminal liability to use the naloxone. This type of opioid overtoxicity may occur in our north side probably. So depending on the local implementation, so getting an AED and getting the naloxone also if suspected overdose is suspected. So public policy should allow possession, use and immunity from civil and criminal liability for good faith administration of naloxone by the lay rescuer. You can see here the naloxone overdose emergency kit are made available for public use. Coming to defibrillation, very important, early defibrillation, because initial rhythm is shockable. Public access AED. You can teach the public how to use the automated external defibrillator. Vector change or double sequence defibrillation is no longer recommended except in refractory cases. Cardioversion is concerned. Some arrhythmias like AF, where we used to start with the gradual increase in the shock from 50 joule, 100 joule, 150 joule. Now it recommends 200 joules of shock in the patient with hemodynamic instability with AF. And we are well aware that as the time period goes, the success of defibrillation goes down as low as 20% if we initiate at 9th or 10th minute. So time is defibrillation. Early defibrillation is what they have recommended. This shows the pad placement. So very important, where to keep the pad. One pad, the bare chest is below the right clavicle, and other on the left side. Instead of apex at the mid-axillary line, middle of the pad should be below the axilla at the mid-axillary line to get the adequate success in AED and other shockable if you are using the defibrillation. These are the ideal places for placing the pad. Simple things have been re-emphasized. If you want to keep the anterior and posterior middle of sternum and back of the scapula, or if you are going to left side and lower side on the left back, this can be used for double sequence defibrillation in refractory cases. The shock recommendation in peri-arrest like narrow complex tachycardia, it is 100 joules, monomorphic VT 100 joules. These are the recommendation cardioversion. And you see for atrial fibrillation or atrial arrhythmia, the shock level is increased to 200 joules. So you start with 200 joules rather than 50 or 100 joules. If there is polymorphic VT, it should be considered for defibrillation. It is not synchronized rhythm, it is unsynchronized defibrillation or shockable rhythm for arrest. They removed the sotalol beta blocker from algorithm and changed the supraventricular tachycardia to narrow complex tachycardia, so more simplified. Post-cardiac arrest is an important period where we have to achieve what we have achieved, the return of spontaneous circulation, to maintain the airway, maintain the advanced airway, try to confirm the correct airway placement. Sometimes in hesitation you might have put the tube too much in, so keep it at 21 mark. See that it is at the carina. Manage the oxygenation. Keep the PCO2 normal 35 to 45 and don't try to rush for oxygen. 90 to 98% is your target for oxygenation. Then go for the early diagnostic test of 12 lead ECG. And if the patient has persistent ST elevation or cardiogenic shock or refractory arrhythmia, this patient requires early angiography. Treat arrest etiology is consider angiography, mechanical support, circulatory support if required. Assess the patient of sedation. If he is not following command, then you should go for the target temperature control, which they call. And if you are not sure, then ongoing critical care, temperature control, and there are multiple modalities before prognostication. So EEG is one, angiography when appropriate, ongoing critical care, and your targets prognostication should come at 72 hours of return of spontaneous circulation. That should be multimodal. How much is the temperature control goal? Is 32 to 37.5 degrees centigrade. So hold temperature for at least how much time? That is 36 hours of temperature control. Maintain blood pressure more than 65 and oxygen saturation to 90 to 98%. I told you special consideration for pregnant female. The things are different here. The difficult airway, physiological difficult airway they call it. So it's a early airway management. Place a IV above diaphragm. Stop the magnesium. Give calcium if she is on. And activate the massive blood transfusion protocol if there is a PPH or hypotension. If there is a fundal height above the umbilicus, you have to display it laterally to give the CPR. Goal is to deliver by 5 minutes if no return of spontaneous circulation. Mother is the priority, you remember. The etiologies from HNTs, that is hypoxia, hypovolemia, tension pneumothorax, transmural MI. These HNTs are common. In pregnancy, you should look for A, B, C, D, E, F, G, H. That is that anesthetic complication, bleeding complication, cardiovascular, cardiomyopathy, drugs like magnesium, fever, and hypertension or preeclampsia. These may be the precipitating causes. So special situation, special things you have to do. Debriefing is very important. So after the event, you should review and reflect. So incorporating immediate, that is a hot debriefing, and delayed cold debriefing or mortality meeting is reasonable to identify different opportunities for system improvement. It is not the person, it is the system. Situational awareness in reducing intra-hospital cardiac arrest. Another important thing, like going for the early morning SOAR, identifying the high-risk hospitalized patient who might go in this, and you can avoid the cardiac arrest. So this is the preventive part of the chain, to identify the situational errors, mitigate the deterioration, and identifying before they go in arrest. Time of termination of resuscitation is very important. When to terminate? So initial rhythm, what was the initial rhythm? Whether it was asystole, how much time was delayed when you started the first compression? Remember the timing, the team's dynamics. What is the age of the patient? Age may not be the major factor. What is the biological age is not important. What is the functional age? What is the comorbidities? How much was the no flow time? What was the CPR duration? Ask this question, and then you will get to individualized decision whether to stop CPR, to continue. Of course, you have to follow your local and regional protocol. Somebody with CA with metastasis, multiple metastasis, with don't try to. You have to have your own policy in such situation. I may not utter that. Pharmacotherapy or drugs, they have reduced the number of drugs used in CPR, focused only on adrenaline. So that comes in PA and asystole as early as possible. Intravenous is of course preferred over intraosseous. Major changes: no drugs through ETT. Initially used to give lignocaine, epinephrine through ETT if there is IV, not a, but now there is no role, no ETT route. Public access naloxone, vasopressin is not used. So IV is the major, adrenal is the major. Lignocaine or cardaron in refractory arrhythmias you may use in shockable rhythm state, that too after second shock. Tenecteplase is added as thrombolytic agent we have been using, but officially now added for the stroke thrombolysis. In special circumstances, anaphylaxis, it is IV epinephrine, no intramuscular IV epinephrine. In coronary adrenaline, intravenous coronary adrenaline, cath lab, there is arrest while doing the angiography process. You can give coronary adrenaline. Of course, personal protective equipment in aerosol generating process. If there is hyperkalemia, don't be dogmatic about calcium, gluconate, soda bicarb. Do your compressions right. Early airway and lateral displacement of uterus in pregnant patient. Focus on system of care and that chain of survival. Community certification, organ donation after cardiac arrest is important. There's awareness about this. Science to practice, the most important emphasis on education, the education to reach the community, to the children's about 10th standard, schools go, public awareness, training of children, virtual game, pillow training, no need of mannequin, and teamwork is all lead to improvement of survival after cardiac arrest, to reach the community. Thank you for your attention. All these details you can get from American Heart Association Guideline Resuscitation reference from Circulation article free. Any queries, call me or mail me on practicaltips@gmail.com. Thank you very much. See you next. Please go to my previous video. Bye for now.